Welcome, everybody, to our CAPE Knowledge Exchange today. Today, we'll be doing our presentation on Let's Talk About Medication Opportunities for Interprofessional Advocacy. And particularly, we're going to be looking at you and your future older adult patients who are at risk for experiencing adverse drug events. I'm delighted to have a national expert here today, Dr. Hedva Barenholtz Levy, who is the director of HbL PharmaConsulting in St. Louis, Missouri, and author of Maybe It's Your Medications. And she will be discussing the role of the interprofessional team, the role of deprescribing, and we're really, really excited for you to be here. This comes to you by CAPE and the UNE Center for Excellence in Aging and Health, UNE School of Pharmacy, and the co-occurring collaborative serving Maine, who will be issuing CEs. And the competencies for today are roles and responsibilities and communication. And I'm excited to pass this over to Dr. Emily Dornblaser.
Thank you, Shelley, and welcome everyone. We're very excited to have you here. Dr. Barenholtz Levy, as Shelley mentioned, is the founder of HbL PharmaConsulting, which is a consulting company with a focus on older adults. And she's the immediate past president of the American Society of Consultant Pharmacists. And she is board certified in pharmacotherapy and geriatric pharmacy. So what that means for us is that she has a lot of expertise in working with older adults and looking at medications. And we are excited to welcome her because I think sometimes we think of pharmacy as often what medication is indicated. And I think she brings to us a perspective of constantly also thinking about when do we not need medications? And that's just as important a question for us to ask ourselves when we're managing patients. So I'm going to turn it over to Dr. Levy and thank her very much for bringing this talk to us.
Thanks, Emily, for the introduction, and Shelley as well. I'm happy to be here. It's an honor to share a topic that's very near and dear to my heart for many, many years. So I'll start by highlighting the objectives for today's time together. I want to talk about polypharmacy and medication overload, make sure we have a good sense of what those terms mean. And then I'll talk about why polypharmacy is so prevalent among older adults and how, and really explaining why it will touch all of us as in our careers as we care for an aging population. I'll talk about what deprescribing is and why it matters, why it's so important. And then very important for me is to leave you with some strategies that you can take with you in your careers and back to your offices on what you can do to help reduce inappropriate polypharmacy among older adults. So just want to set the stage about our aging population. You can see that this first slide just shows the trend of the growing number of persons age 65 and older in the U.S. and the numbers have increased to about 15% of our population here in 2020. We have a projected about another 20 million older adults, just to round up, that will be becoming age 65 and older in the next, say, 15 years or so. During your careers, you'll be seeing more and more older adults, millions more older adults who will be living in the community setting and tasked with managing their medications and their health conditions, and largely living in the community setting. So not only are we getting 20 more million older adults in the next several years, but that percentage is going to increase from maybe 15% of the population or 20% up to almost a quarter of our older adult population will be age 65 and older. So we will be seeing it everywhere, and the older aging population will be touching all of us. By prevalence, when you look at the prescribing in older adults, they clearly are taking more medications than other age groups. So when you look at 5 or more medications, which is an important cutoff I'll be talking about when we talk about polypharmacy, about 41% of older adults take 5 or more medications. Most older adults are taking even at least one medication, roughly 91%. But when you look at compared to younger populations, even 10 years younger and all ages, the older adult population is using a significant chunk of our medications. You can see 41% compared to even half of that, 19% of the 45 to 64-year-old population. And you have to remember that when older adults are taking their prescribed medications, they're also using over-the-counter OTC medications as well. These would be things like your antacids, your ibuprofen, Tylenol, acetaminophen, as well as aspirin. That's a very common one. When I work with older adults in their homes, I ask to see all of their medications as I do comprehensive medication reviews. And it's surprising how many patients don't even think about that aspirin until maybe I even have to prompt them. Do you take aspirin? Oh, yes, I take aspirin. So we have to think about those over-the-counter medications as well when we think about the prevalence of medication use in older adults. And I also have on here the note about dietary supplements. And the dietary supplement market it's regulated very differently from medications. It's a whole other conversation we can have. But dietary supplements are regulated as food rather than as drugs, yet they're readily available to anyone to select without a prescription. And dietary supplements include things like glucosamine and garlic and fish oil, but also all of our vitamins are considered dietary supplements. So we have to be aware when we think about medication lists and what are our patients putting into their bodies that might interact or lead to side effects, we need to consider also that dietary supplement use. This next slide I always like to share because it impresses me so much to look at the expansion of medication use in our aging population. I graduated in 1990. I got my pharmacy degree and started practicing then, so close enough to 1988. But essentially, so far in my career, the percentage of older adults taking 5 or more medications has essentially tripled. I hope that number doesn't go much higher, but I think it's something to just take pause and think about how much more we're using medications, how more common it is. Some have even stated that it's our new normal, this increased use of prescription medications. But also remember, we have a subset of older adults who are taking easily 10 or more medications per month. So again, widespread use of medications in our older population. Recognize also that the frequency of medication use is going to vary based on where older adults live, how acute their health needs are. In the community setting, the average number of prescriptions per day is about 5. In my practice, although it is community-based, I tend to see the more complex or needy patients, more challenging cases, and my average is probably a little higher than that. But they're exposed to 9 to 13 different drugs on average per year and take about 5, just on average in general. In an assisted living setting where there's more dependence on the activities of daily living, they need more support, more probably a little more frail population. They're taking more medications per day, so the average number is maybe 7. It's hard to get really good numbers for some of these settings, but on average, it's going to be a little bit more. And then finally, in the long-term care setting, where we have our frailest population and typically our oldest population, the average number of medications is yet higher for this group of patients, 40%. So nearing 1/2 of long-term care older adults or long-term care residents take 9 or more medications. And we certainly need to think about the consequences of medication use in this population, which I'll talk about in just a minute. So what is polypharmacy? We've been talking about the widespread medication use among older population, and polypharmacy is really what we're talking about. There's a couple different ways to define polypharmacy. The first way is, with the most simple way, is the numerical threshold. There's a number of 5 or more medications. It's kind of an arbitrary number depending on the setting that is being considered or the research project. The number could be 4, it could be 9, for example, but in general, we consider 5 or more medications to be polypharmacy, the use of multiple medications. I think it's important to differentiate that we can have appropriate use of multiple medications and we can have inappropriate use of polypharmacy or multiple medications. If you think about patients who are diagnosed with diabetes or heart failure, they easily are going to be needing 2 or 3, even 4 medications is often not only recommended, but appropriate to manage their health condition. What we run across is what we're concerned about is when we have the use of medications that may not have such a great need or may not be warranted. So it's perhaps more important to look at a qualitative definition of polypharmacy. And so a couple definitions I like to talk about is one is the presence of unnecessary, ineffective, or harmful prescribing, or the use of more medications than are clinically warranted or indicated. So with this, I have definitely seen patients who might be taking 3 or 4 medications, but if one of those medicines is no longer necessary, I think we can certainly classify that as inappropriate polypharmacy. So it may not be so tied to the number. Medication overload is a term that was coined by the Loan Institute in 2019. And I like to bring this into the conversation when we talk about polypharmacy, because it's another way to help us think about the problem. It gives it a different term. We might lean in a little bit differently for those of us who have heard about polypharmacy for many, many years. Not that we're getting attuned to hearing the term, but when you hear medication overload, what's that? And medication overload has been defined as the use of multiple medications for which the risk of harm is greater than the benefit. Very similar to that concept of inappropriate polypharmacy, with, I just want to emphasize that part of harm, and certainly our first tenet in medicine is do no harm to our patients. So when we have medications that can cause side effects or otherwise adversely affect a person's quality of life, that's when we have inappropriate polypharmacy or the medication overload situation. Recognize that polypharmacy is taking 5 or more medications, taking 5 or more medications, sorry. It's a risk factor that could be a signal for being at increased risk of problems. So if we think about why do I harp on the number of medications used and how prevalent it is, think of how many patients are at risk of having additional problems related to their drug therapy. And on this slide, I only want to emphasize, again, the issues with consequences of polypharmacy, whereas the U.S. population is, that is over age 65 is about 14%, give or take, of our population now. It's taking up about 30% of our healthcare expenditures and drug expenditures. So this small percentage of our population really matters when we look at overall healthcare costs, and what we can do to impact our patient care. So how did we get here to this prevalence of medication over medication use, if you will? So I like to pause even before showing this slide. What would come to your mind? So think about it for a minute. Certainly, we have a lot more medication use today because we have an aging population, right? We have 10,000 older adults turning 65 every year, 20 more million we'll get to in the next 10 or 15 years. And with aging comes chronic health conditions. And chronic health conditions typically require medications. We do that very well. So even if someone has 4 or 5 very common health conditions as we get older, maybe arthritis, osteoporosis, glaucoma, cardiovascular conditions, diabetes, you can see how the number of medications would add up very quickly if someone is taking even one medication for each of those conditions. We have advances in medicine and pharmaceuticals. I think we have to be very grateful for our pharmaceutical manufacturing and research and development that goes on. We have medications that are now helping us survive strokes and heart attacks and cancer and HIV, and how we address the COVID crisis with the vaccines. We have wonderful advances that bring to option many, many medications to treat more and more diseases. And I always comment as a pharmacist, I'm always amazed that we're finding yet another mechanism for another disease state and a way to use drug therapy to help our health. So there's more and more options and advances with pharmaceuticals, and also medicine understanding disease. We have a lot of advertising out there. Think about you're turning on any TV at any time. I know for students, you don't always have the time to be watching the television, but there is so much advertising out there. Note that only New Zealand and the United States have allowed this direct to consumer advertisements. So it's kind of unique in our country that we have all of those advertisements. I think there's two sides to the advertisement. It does help with awareness for certain disease states, and it also, I think, drives some of our prescribing a bit. And even we see non-prescription medications being advertised and those dietary supplements. So there's a lot of advertisement. We have an internet access that is certainly helping people get ideas for what they might want to take, or what might want to ask their prescriber about. Dr. Google is widely accessible and used by so many people, and as our population is aging, they're more and more comfortable using the internet. So there's information on the internet that may be not so helpful or might be helpful, but it certainly can encourage medication use. What about our culture? We have this pill popping culture. I think a lot of the things I've just talked about kind of lead towards that. We have a pill for every ill, I've observed. And it certainly is easier for many Americans to want to take a pill to fix the problem rather than to maybe take that harder road of changing a lifestyle pattern, diet, exercise, something like that. So we have a culture that kind of feeds into, we've got a medication for that. What about the training of healthcare professionals? So think about the training that of everyone here on the call, and those of you who are practicing. What was your experience with geriatric training? The numbers are very low. Less than 2% in general of physicians and pharmacists are geriatric trained. I think the number is less than 3% of advanced practice nurses. When you think about the percentage of a population that is aging and the nuances for geriatrics, understanding the medications and how they act differently in older adults and how older adults respond differently to medications, that training is very important, but not every healthcare professional that an older adult works with is going to have that training. And then our healthcare system, we have an insurance system where that they reimburse us for medications. I think it's growing a little bit, but how many insurance companies will reimburse for the gym memberships and food, nutrition, dietitian, nutrition information, things like that. I think it's growing, but we have the insurance coverage for medications. When Medicare Part D came around, now it's been about almost 15, 20 years. We're getting close, 15 years or so. That was a huge thing, that medications could be covered by insurance. So more medications are accessible financially to older adults. And then we also have a system that reimburses healthcare providers on these 7-minute doctor visits. I've heard the number thrown out several times that the average length of a doctor visit is 7 or 8 minutes. So do the physicians have time to spend with patients to really talk about their overall health and how we can address health conditions and help our health without jumping to a medication or prescription necessarily? So I think it's important to, although this is a busy slide, but to consider all of the factors that go into the excessive polypharmacy that I think we have in this country. So with that, I wanted to just set the stage for why we really want to be talking about this with each other, with our colleagues, with our interprofessional teams. We'll go into a breakout session. We'll take about 10 minutes there. I encourage every group, designate one person as your note taker. Introduce yourself and your discipline, a little bit of your background. And then I put out 4 questions here so you guys can talk off of these questions and explore polypharmacy from different perspectives. Just to see where you are and what your experience has been. I think it would be interesting to hear what your comments are. So the 4 questions we put out here is, do you agree with the statement, we are a pill popping culture? Have you seen polypharmacy in patients, family members, anyone around you? What's your experience with seeing this multiple medication use? And what concerns might you have with the patient who is experiencing polypharmacy? And finally, what problems might you have seen that are associated with or seem to result from polypharmacy? So with this, I'm going to look to my crew and we're going to go into a breakout session, 10 minutes, and then we'll reconvene. And as you're in your groups talking, that note taker just highlights a few things you want to share. You'll put in the chat group when we return, and we'll talk about some of your feedback. Fair enough? Curious what you guys talked about. I was interested with my group. It was a small group, but I got some good feedback. So take a minute real quickly to throw in some of your thoughts. And thank you to you note takers and those of you who are populating the chat box for us.
Thank you, Michelle. That's a good comment.
About the international.
Well, it speaks a lot to, I think, to the culture and how culture impacts people's perceptions of medicine.
I heard a lot about communication or miscommunication, that the number of medications that folks are getting on their reports from doctor's visits, you know how you get a handout when you leave, to go over all of those medications is almost impossible. And patients tend to be embarrassed to ask or just don't know what to ask. So communication is so key. And so the question is, who needs to know how to communicate that information with the patient? Is a follow-up necessary?
I'm seeing a big theme of lack of any one place where all the meds are, which is huge. So, you know, generally when you go to the doctor's office, you're trying to go through a full med list, but that patient might not remember everything they're taking when you're reconciling those drugs. So you never know what they're getting. From the pharmacy world, there's lots of incentives to move your medications from one pharmacy to the next because they offer coupons for fill. So if people have challenges paying for medications, they might have their meds spread out or at 3 or 4 different pharmacies, which means that when a pharmacist is filling prescriptions, they don't have a full med list to check those drugs against, which can be very dangerous. So we always say, like, try to keep all your meds in one pharmacy. Let's see.
Language barriers, education about the indication, why people are taking their medicines. To me, that's huge, to be able to understand your medicine. So, and our group talked a little bit about, not having complete instructions on when a prescription is written. Take it as instructed or as needed or as instructed without the details. Not know why, financial burden. So people are seeing the impact of polypharmacy, right?
Oh, I see a good one in here, mail order pharmacies. So that's another one where mail order pharmacies are designed to decrease the cost of filling medications, and also theoretically assist patients who might have difficulty getting their medications filled. But what can often happen is people keep getting meds mailed to them and it never stops if the medication's discontinued. So it's also very hard to communicate discontinuation of a medication to a pharmacy, right? Like, there is no order discontinued that comes into a community pharmacy typically. So as pharmacists, like, we have to kind of be asking the questions, are you still being instructed to take this, and make sure that we're trying to keep our records up to date. So that actually, I had never even thought about, like, just direct communication about discontinuation. In the hospital, it's very easy to discontinue an order. But how do you do that to a patient that's filling their prescriptions as an outpatient?
Yeah, there's a really good one in here that our group also touched on. So group 2 talked about the overlapping side effects of medication. So which one, when you present with a side effect, what is the medication of concern? And if you're unable to kind of weed through that, we just kind of slap on another med, and then that's the prescribing cascade. And polypharmacy increases, inappropriate prescribing increases. The other one I thought was interesting was the lack of ownership of specific medications, or the problem of not knowing who owns, quote unquote, owns that med. So if a cardiologist prescribed cardiac medications, can the primary care provider discontinue them? And now it's not just we're not communicating. It's we're not communicating what we're not saying. We don't know whose role it is to stop. And so us pharmacists are saying, well, it's anyone's role, right? But providers feel uncomfortable. There's that ownership, that responsibility, and you're not sure who would be offended by that or not.
We'll get into that. Talk about the deprescribing barriers. So these are great points. And I think we'll wrap up in just a minute. Emily, was there one more you wanted to highlight?
I was going to say the same thing. We talked about how in pharmacy, you get to see the whole profile, but sometimes you end up bouncing back and forth between different physicians to try to figure out who will discontinue a medication that's not indicated because there's a lot of like, if I didn't start it, I'm not going to stop it as a philosophy, but that can be really, really hard then to find the right person who's ready to discontinue. And a lot of times it's facilitating conversations between specialists. So we end up being sort of the middle person between these two.
I will have to say, just to touch on the medication and the multiple pharmacies too, this is the national shortage with some of the medications. I have to drive an hour and a half for one medication, fight with whoever's filling my prescription because they don't understand mail order versus, picking it up somewhere. And then I need to go somewhere else for another medication so that I don't have to drive an hour and a half. And then I'm like not getting my medicine and I'm not feeling okay. And now I'm supposed to take care of people who don't feel okay.
Yeah, huge challenge. The shortages are really, really challenging.
We just have to advocate legislatively, because honestly, if all these larger insurance companies, the commercial ones, are requiring that we use this place and that place, it's not convenient for everyone. And it's going to populate more medication struggles, managing them. And with psychiatric patients, they're not always that great at taking theirs anyway. So now we're adding another barrier.
100%.
And
PBMs.
The gaps in our healthcare system and the way it's set up certainly is rife with problems. And another session you guys can have, right?
We'll kick it back to you, Dr. Levy. Go ahead.
Yeah, wonderful. Thank you. And I just wanted to mention this: the holy grail of having an accurate and complete medication list is something we are still looking to find. I'm only looking. I want to move my video screen. I'll be okay. I have my little screen issue here, but we are good. So let me go back to that slide. So we talked about, I think everyone can recognize that polypharmacy is there. It has many impacts. So let's talk a minute about the consequences of polypharmacy in older adults. And as you move left to right across this slide, you move a little bit farther away from being able to say it's definitely related to the medications, but studies have definitely found associations with all of these consequences that I've put on this slide. Certainly when you look at adverse drug reactions and drug as well as drug disease interactions, and that's a whole other lecture in itself, as well as adherence, that ability to follow the instructions of the medications, to take all of the medicines as they are intended. The more medicines a person has, the more you're going to see these risks, the greater the likelihood of these consequences are going to be present. And we know they're very closely related to the number of medications. Sorry, how to get that out. Moving a little bit farther away, the geriatric syndromes is another very important topic when we think about geriatric care. And some of the syndromes that we've seen associations when you're controlling for other factors that are associated with polypharmacy: falls, frailty, maybe the decreased renal function could be associated with polypharmacy. A little question mark there. Also, studies have found an association, again, controlling for as many factors as possible. We've seen a positive inverse association with physical and cognitive function. The more polypharmacy, we see a decline in physical and cognitive function. Things measured like time to get up and go test, walk time, gait balance, strength, hand strength. So these have been associated with the more medications a person takes. A little more vague, but it's there and to be aware of it. And then finally, the hospitalization and healthcare utilization, as well as mortality. Again, we find associations with polypharmacy. You can think in general, when we have more medications, each one has a copay, you have direct costs that are going to increase, but we're also seeing the downstream effects of an extra doctor visit, an emergency department visit, even a hospitalization. And I'll touch on mortality for a second, just because in the last several years, when you look at the research published on polypharmacy, there's been a handful of drugs that have found an association with mortality, and a pretty strong association that seems to have a dose-dependent relationship, if you will. The more medicines, the higher that mortality risk. Pretty non-specific, but it's something to keep in the back of our mind when we're using all these medications, when we have long medication lists. what is happening? How are we ultimately affecting our patients' care? And then quality of life across the bottom. Polypharmacy clearly has many ways it can negatively impact quality of life. So a lot of things to unpack in this slide, but the consequences are very broad and important to consider. In this slide, I almost wanted to talk about earlier, but I knew it was coming, so I save it for now. But how big is this problem of polypharmacy? This was a quote from an article in JAMA. It was about hypertension, treating hypertension in older adults, but it was written by a physician in a medical journal. And I thought it's a pretty powerful statement. Polypharmacy should be considered as a medical condition like any other that has adverse effects and complications. And if you think about polypharmacy in this sense, what a difference that might make, right? If we attended to polypharmacy as if it were a health condition, we would be thinking about what's causing it, what are the impacts, and how can we reduce it, right? So I like putting that quote out there just for you guys to think about. Okay. So the next slide we'll the next slide we'll move into is, let me make sure I didn't go ahead too far. Sorry about that. Strategies to address this medication problem. So what steps can you take as healthcare professionals to reduce this inappropriate polypharmacy, or use the term medication overload, if you will? How can we advocate for our patients? Because I think it takes a team, our community, it takes a healthcare team, including a team that includes the patient, to advocate for a patient's well-being. So we talked about the problem and the consequences. What can you do? So I'm going to introduce 3 general concepts to you that I think apply, or I know apply across any discipline, no matter where you're practicing, what your specialty is, that I think you can take home with you and incorporate it into your patient care. So I'll go into, talk about each of these separately: the deprescribing, person-centered care, and then shared decision-making. So first of all, what is deprescribing? I'll talk about this for a minute before we talk about how we can get into the encourage deprescribing. By definition, deprescribing is the systematic process of reducing doses or stopping medications that no longer are needed or of benefit to a patient. And so I want you to recognize in here, it's not just stopping, it's also reducing doses. So it's optimizing medication, if you will. It's a process that has to be done one-on-one. Every person is different. Therefore, it has to be very person-centered. I like to share with people that I have this love-hate relationship with the term deprescribing. I've been optimizing drug therapy for decades, one-on-one care, evaluating drug therapy, and providing very personalized evaluations and recommendations. And then we have this deprescribing communication. This movement is all over the place. And I've come to terms that we need to have this term deprescribing. We need to have a movement, if you will, because we need more information. Deprescribing does not come easily. I'll talk about some of the barriers. So as we focus as a healthcare, from a global healthcare perspective on how to deprescribe and what's involved in deprescribing, we can grow our evidence base, because one of the hesitations is, how can I stop a medicine? A person has been taking it for 5, 10, 20 years. Is it okay to stop? How do I stop it? Which ones can be stopped? So we need research, and we also need to name it and talk about it so we can grow our stakeholder engagement. So who are the stakeholders in safe and effective medication use? I think everyone on this call is a stakeholder for sure. But our patients matter. They are stakeholders. Our payers are stakeholders, our prescribers, and everyone who's trying to help our older adults age independently have a stake in understanding the deprescribing and how we can affect it better. So what do we know about the deprescribing? I mentioned it's hard. So what's going on with that? How do I unpack it a little bit? I want to talk about the patient perspective and the physician's perspective, because that's where most of the research is. And we talk about patient perspective. We know across the board that if older adults are told that they could stop a medication, if a physician said it's possible, would you be willing to stop? Upwards of 90% across the board want to be able to, are willing to stop a medication. More than 65% say they want to take fewer meds. In the same surveys, we're seeing patients, a large percent, believe their medicines are needed and they're reluctant to stop if they've been taking a medication for a long time. So there's a little bit of disconnect here, right? They're willing to stop if a doctor says it's okay, but I really like what I'm taking. And on the right side of the screen, there's another study, I included it because it's a little more recent, that looked at patient and caregiver perspectives, and basically it says the same thing. Caregivers have similar perspective as the patients. They're willing to help their carer, the person they're caring for, their care person, stop a medication if the doctor says yes, but they're also pretty satisfied with what's going on. So there's something we need to get at, but for patients to understand that there is an option for deprescribing, if you look at the bottom right of the table, patients and caregivers need to be involved in their deprescribing. We know that they're more willing to bring it up and talk with the doctor about stopping a medicine when they're involved in their drug therapy. And it also comes across loud and clear in studies that caregivers and patients need to know there's an option. So again, there's some role in here that we can play to help our patients be more open to deprescribing. What are physicians saying? They're small studies, but it's very representative of other studies that have been done. So I just wanted to highlight these. Physicians feel in general that there's challenges that impact them, why they can't deprescribe so much. Patients expect sometimes the medications. We have a medical culture that promotes prescribing. I talked earlier about our reimbursement system and the insurance and what have you, and the length of office visits. But physicians also want to do the right thing for the patient. They know that patients are at the expenses and the adverse effects and interaction concerns, but they feel they're swimming against the tide. So if they could have more support where that research comes in, computer alerts, communication across between providers, access to advice, that research, it would help them. I like this bottom study was published this year, a little bit larger, but again, focusing on physicians, kind of doing an overall survey and then drilling down to specific comments from these physicians. The perspectives were generally that physicians, that it was looking more the perception of health literacy, and physicians felt that patients didn't have the strong health literacy to support the deprescribing. And it came across that it would be easier for the physicians if the patients would kind of bring up that conversation about deprescribing. So I think it's important here just to pause and recognize what might be a little bit of implicit bias going on, right? If we're assuming patients, it's too complicated for patients to understand, they don't have the health literacy, we're putting assumptions on them that may not be the case. So I think we need to be aware of our interactions, our perceptions with the patients, and recognize that we can still talk about deprescribing. And this slide summarizes all those different barriers. I'm glad that some of this came out in our earlier conversations. From the patient's perspective, why is it hard to deprescribe? You saw that first slide where they want to, but maybe not. Patients are concerned maybe that their symptoms will progress, right? They've been taking a medication for years, sometimes decades, we see. What if we stop it and the symptoms comes back? Many patients have a psychological connection. I've seen this a lot with my patients, but I need this one to help me sleep or for my anxiety. So we recognize patients have this psychological connection. They don't want to upset the physician. The doctor prescribed everything. Who am I to question what the doctor has prescribed? I don't want to upset him. But then if we talk about stopping medications, maybe there's also the fear that the doctor is giving up. So I don't want to go down that path, right? So it might be a barrier for patients. And then this last piece, I think it's more and more important to talk about patients being unaware of non-pharmacologic or non-drug options. So again, we all have a role, again, thinking about your discipline, where we might be aware of non-drug options to help patients. From the physicians, we've talked about this a little bit, the lack of training. We need more evidence base. Physicians also are worried that those symptoms are going to come back for the patient. They have the quality metrics. If they don't meet certain guidelines of, treat patients to their clinical practice guidelines, for example, they're going to get dinged. And so physicians don't want to deal with that. We already talked about who prescribed it. Someone else prescribed it. I don't want to touch it, or I'm afraid to touch it. Not knowing when and why medicine was started, right? So I'm encouraging patients to note on their medication list who started the medication for them. So that helps with that when we get to this deprescribing piece. and then also the lack of time that it takes to deprescribe and talk to patients. We've talked about the health culture in the U.S. A little bit with the metrics for prescribers, with the pill for every ill. Clinical practice guidelines are important to remember that each guideline in general, most of them are designed for one health condition. They don't take into account patients that might have multiple health conditions. And when you apply different clinical practice guidelines to one patient, the number of medicines can add up quickly. And then going back also to that last bullet point under health culture, that the lack of awareness that we can't even deprescribe. So how do we normalize it and talk more about the deprescribing movement? Which brings us to the first strategy I believe you can all take with you, is to embrace this deprescribing movement. Now that you understand a little bit about what it is and some of the barriers, if we start talking about deprescribing, pulling back or stopping as part of the continuum of when we prescribe, it will normalize this whole idea that medications aren't necessarily for life. So how do we continue to grow awareness? What research can you do and keep putting out there? And I know Dr. Springer at the College of Pharmacy is doing an awful lot to contribute to that type of literature. But we need the science and the guidance, and these guidelines are evolving. I think it's important to normalize this idea that medications need to be routinely reevaluated. In the medical literature, someone introduced the term re-prescribed, right? We're going to relook at things and continue them when and if we know they are necessary. So we have to watch the duration, that we have an indication, and recognize that medications may not be for life. The second strategy I think we all need to fully embrace is the idea of person-centered care. And what matters most is central to the 4Ms framework of age-friendly healthcare systems. So anything we do with prescribing or deprescribing or helping an individual manage their health, it comes down to what is most important for that individual. So the healthcare choices need to reflect the patient preferences and goals, and that includes their medications. So where does a person stand regarding drug therapy? There are patients who absolutely want that pill. And I think I caught something in the chat where someone might want the medication. It's easier for them. Others might not. And they're going to be the ones more inclined to take on those harder lifestyle changes. So think about from your discipline, whether you're medicine or pharmacy or social work or physical therapy or occupational therapy or nursing, etc. What is your perspective when you are talking with your patient about their health care and what matters most to them? The third concept is the shared decision-making. And many of you, I hope, are well familiar with these tenets of person-centered care and shared decision-making as part of our new paradigms, or renewed. They're not new, but they're renewed focuses in healthcare as we're looking more towards quality healthcare. Shared decision-making ripples through everything, all of the recommendations and guidelines and quality improvement efforts. Patients and caregivers should be part of the healthcare decisions. They need to be part of the decisions, but to do so, they need to be informed. So what can we do as healthcare providers to make sure patients and their caregivers have the sufficient information necessary about any care option, if you will? But from my perspective, and today we're talking about the medications, and to recognize that medications have benefits, of course, that's why we're looking at them, but they also come with risks. And so how can we inform our patients about both sides of that equation? Ideally, with shared decision-making, patients, caregivers, and healthcare providers are going to work together to reach their healthcare and medication decisions, and we'll talk about the value of that in just a second. Shared decision-making has to be a two-way conversation, and for better or worse, it's going to take more than a quick interchange. It might take a little bit more time. So how can we make our flow, the patient care flows, incorporate some opportunity for that two-way conversation? Ultimately, this whole shared decision-making is out there and reinforced as an important paradigm of how we provide healthcare, is because we want to improve those decisions about medications. Do we want the medication or not? Ultimately, this would lead to improved health outcomes. But for me, most importantly, is having patients have a greater satisfaction and quality of life when they're more engaged and in part of their decisions, for sure. This slide is just another way to kind of summarize what I talked about with what shared decision-making is. It's an important paradigm shift in how we're delivering our healthcare Patients need to be informed about their treatment options, benefits, and harms, and caregivers are largely involved with the older adult care, so I always want to include them. And patients then actively need to participate in healthcare decisions, and we need to help our patients understand the choices and help them come to good decisions for them. Again, what matters most to them, the patient values have to be included. And all of this applies across healthcare, all of our training, but medications for sure also. And the value of involving the patients in their decisions regarding their drug therapy and deprescribing is because patients ultimately, and their caregivers, are the ones to carry out any therapy plan. So we need their buy-in. And if we think about medication use and adherence issues, are they taking their medications? If they don't believe that this is a great choice for them, they're less likely to adhere to those medications, and it's going to hinder a positive outcome in their drug therapy. Also, I feel strongly that to empower older adults to recognize they're the first ones to notice any possible adverse drug events. So I want them to be empowered, to be encouraged to share their experiences if they do feel differently, if they think they're having a side effect, to bring it up to their healthcare team, bring it to you. Maybe they're more comfortable with someone who's not their physician, for example, but you might be hearing something. How can you bring that information back to the healthcare team to improve the patient's quality of life and their overall experience? But patients should be encouraged to ask questions and be part of that active member of their healthcare team, which is that last point that I always say patients are the most important part on their healthcare team. And I don't know that older adults, any patient really recognizes that they're a main player in their healthcare overall. So they need to be involved to overcome those barriers that we talked about, those patient-related barriers. So we're hopefully right on time here. We're going to talk about a patient scenario and then go into another breakout session. So you will have access to this information, I think, when you're in your breakouts, but I'll read through it here. So Mr. N is a 78-year-old gentleman. He's at the clinic today for a routine office visit. He complains of pain in his back and both knees. He's 5'10", 210 pounds. His blood pressure today is 145 over 79 sitting, and it drops to 120 over 70 when he stands up. His heart rate is at 60. Under review of symptoms, just a couple things to highlight. He states that his appetite is okay, but he does feel foggy in the morning, which he doesn't like too much. He does state that he has dry mouth. His bowel movements are not super regular, maybe every 2 or 3 days. He comments that he does have straining. His past medical history is significant for high blood pressure, hypertension, osteoarthritis, probably in his back and knees, if I were to guess. He has some neuropathy, which manifests as tingling in his arms and hands. And he's fallen, he fell 3 months ago. He tripped over clutter. So he has a history of a fall. And here's the medication list. And I did you a favor. I didn't make it super long, but it's enough for you guys to look through and find some juicy issues maybe you can identify or think about polypharmacy for this gentleman. So he's taking acetaminophen, 650 milligrams, 2 tablets every 6 hours for pain, aspirin, 325 milligrams daily to prevent a stroke or heart attack. First prevention, primary prevention. He has never had a stroke or heart attack in the past. For his blood pressure, he takes lisinopril 20 milligrams once a day, hydrochlorothiazide once a day, and metoprolol succinate, the long-acting version, once a day. For his neuropathy, he's got gabapentin 600 milligrams 3 times a day, and nortriptyline 550 milligrams at bedtime. And so I've thrown in the drug classes, the categories, in case that might jog your memory or thoughts about some of these medicines. As needed, he takes the generic of Norco type product, hydrocodone and acetaminophen, 1 tablet every 6 hours as needed for his pain. And he has the dry eyes, so he uses the blink artificial tears. Okay, so from here, we're going to go to a breakout session. We'll have 10 minutes again. Designate one person to be that note taker. So I want you to be ready to drop comments again in the chat box for us. And talk about these questions as an interdisciplinary team. So starting off with, what questions would your discipline bring to the table to help this patient reduce his polypharmacy? What are some person-centered questions or information that would be important to gather? Not a lot of information, what I gave you. What more might you want to ask this gentleman? And then what non-pharmacologic strategies might be appropriate for this gentleman? So again, from your different disciplines, I'd be curious what you would bring to the table. And then finally, we can drill down to the drug therapy piece of it. What concerns would you have specifically about some of the medications or the combinations or how he's taking them? So with that, I turn it back to the group. We'll go into our breakout sessions and we'll reconvene in 10 minutes. Thoughts in your chat box, and we'll play the same game. Emily and Sydney will help me read through the responses.
And Hedva, there's about 30 seconds before we're all back, I think.
Great. Okay, I'll pause and say it again in 30 seconds.
I had some great conversations happening in the breakout rooms I was in, and I think our attendee from the furthest distance is from Oregon.
That might be someone I know. I wonder.
That might be someone you know, actually. Yes.
I threw a link out to a few people. Oh, that's great. Let's see.
So I think you're good to go.
All right. So if people want to drop their thoughts into the chat of things that you guys talked about in this case, it was a good case. Oh my gosh, there was so much to talk about. I could have gone on for hours.
Good. I have to tell you, Sydney and I worked on that one, so I'm glad. We wanted to give some low-hanging fruit there, but other fun things I'm sure we didn't think about. So I'm reading about the falls and fogginess from a nursing perspective.
Yeah, I agree. The fogginess and the falls are huge. I think, like, I always think of fall risk being within my physical therapy folks always are kind of thinking about falls too. And nursing, there's so much going on with this patient that could be causing and triggering falls, medication related. Let's see what else.
Think about his earlier functioning versus how he's doing now. I just want to get some, because it's so easy to jump right to go to the medications, but some of those other things we want to know about from this gentleman. How's he doing now versus before?
Yeah, I think our team kind of wanted to get past stereotyping older adults who are, you just get more tired, more sluggish as you get older, rather than really getting a sense of his pre-functioning and how the medication might be contributing to sluggishness, rather than it being just a stereotypical idea about old age.
And that ageism is such an important concept. So Shelley, thanks for sharing that.
We had a social worker in our group, and she was talking just about access to the meds and the ability to manage this many medications. And is the patient taking them correctly? And how do they keep track of all of their medications and thinking through all of those things, which ended up prompting us to start talking about, if there's so many meds on this list, is the high blood pressure we're seeing due to them not understanding how to take their medications? Is it, or not?
They could be taking extra and we're not realizing it, or who knows, right?
Right. Well, I like group 6, pursuing lifestyle modifications to reduce blood pressure. And were all these blood pressure meds prescribed by the same doctor?
So information that was not provided. That's a key point. I saw some couple comments about the aspirin. We kind of put that in there, that primary prevention. You guys recognize maybe that's not needed, and certainly there are risks with it. So good call on that. Someone mentioned depression. So
Eve has a great question. They said that they looked at the hypertensive medications and all of them were mentioned on the Beers criteria, but they weren't sure how to actually decrease those or talk about a risk versus benefit of a cardiac event. So what do your thoughts be? I think, did I see metoprolol, lisinopril, and hydrochlorothiazide were listed?
Correct.
I remember correctly.
I'm trying to think where they appear on the Beers criteria. With my group, we talked about with the diuretics, you have to be careful with volume depletion and something with older adults for that, and the risk of falls. This gentleman, I hope most of you caught the orthostatic hypotension, so that sitting versus standing blood pressure certainly would increase his risk of falls. Remember with the Beers criteria, I'm trying to think, I want to address that, Emily, since you brought that up, as far as these are the AGS Beers criteria, or the STOP criteria is another tool to know about. they're cautionary flags. It doesn't mean the person, you have to avoid these medications. It means use them with eyes wide open. If there's a safer option, go to that if you can. There often may not be. But with the multiple blood pressure medications, I think as pharmacists, we look at adherence. How's the person taking them? Maybe they've been added and he's not taking the metoprolol at all, and someone keeps adding another medication. Emily or Sydney, what would you add about the Beers criteria?
Yeah, I would add, I think I would take a look at all three and then decide which one is causing the greatest risk first, is how I would approach it. So to me, this person already has orthostatic hypotension to begin with, and that's going to cause a potential fall risk. So that is going to be most likely related to the beta blocker that's on board. We also know that the hypertension guidelines have dropped beta blockers from first-line therapy anyway. So I would probably be most comfortable stopping the beta blocker and looking at, adherence and seeing how well he's taking the meds. And then are there tweaks we could make to the other medications? He has some room to go on hydrochlorothiazide. So instead of adding another first, could we maximize the other medications he's already on instead and get rid of the drug that's going to cause a fall risk in this person? And that we already have documented like adverse events that are happening from the beta blocker. That's probably what I would start with. You're not going to solve all the problems in one single visit either. It's a stepwise approach with the patient. So that's how I would handle it. But I'm not a gerontologist, so I don't know, Dr. Springer, any other thoughts?
I completely agree with what you said at the very beginning. You could talk about this honestly forever. Because there's you could pick every single hypertension med and there's a pro and a con to each one in this particular patient. To talk about the Beers criteria very briefly, I always say, if a drug is on there, you can start with the Beers criteria, but honestly, start here, don't end here. I tell my students that all the time. It shouldn't be your one-stop shop. If you're really reviewing medications, you're using other criteria, like the stop-start criteria, which deserves its own other conversation. Implicit tools that require judgment, like the medication appropriateness index. And just using your own concept and understanding of what the patient is, what's going on with them. And so I always say lowest effective dose, reduce as much as we can, find a way to get, two birds, one stone. So, is there a drug in there that maybe can manage multiple indications versus just one? I'm all about stopping that beta blocker. I always think about, the role of diuretics. As you increase the dose, you get this big drop at change in fluid, and then that can result in orthostatic hypotension. But long-term drugs like hydrochlorothiazide, have more blood pressure management and less of that diuretic component. But then you have to think, is he falling because of changes in, chemistry, right? So you'd want to look at their labs and what else is going on. There's so much more there. But certainly duplicate therapy. So I think that's probably what they're identifying in the Beers criteria. So
if I can add to that, because I think Casey made a really great point in the chat, and the chat is amazing. It's so lively today. Is prevention. We can look at the medications, we can look at what's going on, but prescribers also need to think about other kinds of preventive measures, interventive measures. He may be falling or being lightheaded because he's not eating well, and are we asking him those questions? And, there, again, I come back, I think we agree, Dr. Levy, that ageism is a big part of that, and assuming, and assumptiveness is a big part of that. So prevention, education, activity, getting in there while you're reconciling and thinking about medications and how we can all communicate those with each other to get a balance for Mr. N.
Yeah, I think one more statement, because we talked about aspirin and how a lot of people treat aspirin as if it's a vitamin almost, because it's been around forever. And there's been these old adage of just take a baby aspirin and call me in the morning, but people don't appreciate the risk. And so, this guy was on a lot of aspirin, didn't have an indication to be on aspirin at all. And so tuning into that to see, was it because somebody suggested it to him, or was this his initiative. And if it was, it shows a willingness to be preventative in health and shows a buy-in to wanting to prevent cardiovascular disease. And so, I think as a provider, you see that, and rather than be critical and say, like, you definitely shouldn't be taking aspirin, you can frame it in a different way to say, like, it looks like you're really interested in trying to prevent cardiovascular disease. Here are some safer ways to do that, because that aspirin is actually going to put you at risk. And so, I think that's pulling that patient back into the conversation again to make them feel like they have control over their disease states and things.
And meeting them where they are. I like that comment a whole lot, Emily. So thank you for that. All right. So are we okay to go back to our
finish up? Sorry.
Continue and wrap up. So this slide is just to kind of think through all that we just talked about. The clinical management decisions is something we're all trained as clinicians, and it's forefront in our mind, but we have to incorporate also the psychosocial considerations, and also a person's environmental, financial, educational, all those social determinants of health that are part of who our patients are. And when we work with geriatric patients, they have a whole lifetime of all of these factors that make up who they are and where they are in their healthcare, and what their beliefs are and what their willingness and priorities are. So these are all opportunities for you to advocate for your patients. And again, being a pharmacist who is just so passionate about improving how we use medications in older adults, we need to talk about these medications. And I hope this conversation has given you an idea of how many different ways that the medications impact an older adult's overall health care. So in concluding, getting towards my concluding here, and I do want to talk a couple extra things here, but the 4 M's of age-friendly healthcare, the slide I had up before, but I think it speaks to all of us. When we provide age-friendly healthcare, what matters most is that key piece, like Emily was sharing, where's the patient coming from? Recognize a way to connect with the patient to help them provide healthcare that meets their priorities. But we all have to acknowledge the positive impact of medications on a person's mobility, their cognitive function. I talked about consequences of polypharmacy earlier, and just the impact of those medications themselves. And I always, when I look at the 4 M's, I think right away how medication affects everything. If you're not a pharmacist, you're going to look at it a little differently, but really that patient-centered care is so important when we try to advocate for our older adults regarding their medications. And I just want to read these 2 quotes from this research article I found from a couple years ago, but it was so intriguing because it fit right into what we're doing today, which is talking at the educational level. As you guys are learning your disciplines and going forward in your careers, many of you, students and healthcare professionals, I know we have both on the call in the meeting here today, need more exposure to and understanding the public dialogue, need more exposure to understanding the public dialogue, and to understand the importance of being a patient advocate versus just delivering care as a clinician. So just recognize your role as an advocate for your patients. Rather than informing patients that they need a medication, patients need to be informed about benefits and potential harms of a medication. So again, both sides of the equation, because a medication may not be the right thing for that person, or it might be, but we need to be very mindful of how we do that, of how we choose our drug therapy. So hopefully I've made clear where that shared decision making comes in. So I have references, lots of them, and on this last slide, I open it for last minute questions and that kind of thing. But I wanted to just pause and share with you come back to this book, because when we first talked about me presenting and being this national expert in this wonderfully important topic, Maybe It's Your Medications is a book that came from all of that I've seen in working with older adults in the community, and the errors that can happen from every perspective, from the patients, from the prescribing, and from even what's being dispensed at the pharmacy level. But it's all about advocating. So I just wanted to just share with you that this as a tool that I think will help us all talk about medications and how we can advocate for our older adults. So I just want to mention that as we kind of wrap up and shift to questions. But you guys have such an important role in helping us all address this medication overload, medication polypharmacy situation, because our older adults really depend on us a lot. So I'll leave it at that.
Thank you so much, Dr. Levy. This has been such a great conversation. I hope other people are just as excited about it as I am. I'm sitting here jazzed and wanting to go back and fix so much on that patient case. So, and everybody that was here today, thank you so much for dropping your thoughts into the chat. If anybody has extra thoughts, please feel free to share them. It's been a great time.
And I appreciate the back and forth. So thank you for those who did share in the chat and for doing your breakouts. And I really, again, thank you very much for inviting me and letting me be part of this conversation with you guys.
And thank you so much, Dr. Levy. I think you enlightened so many of us, those of us who are prescribers, those of us who work with prescribers, and those of us who are patients. I think that is really important, and have loved ones who are older adults. So folks, if you haven't clicked in, if you haven't done your attendance, here's the QR code. And also for those who want CEs or CMEs, this is the way to do it. Click in and it will take you to where you need to go. I just want to plug next week's event, which is going to be amazing. It's on clinical and community impact of violent crime, violent behavior. We're going to be really looking at gun violence, the predominance of gun violence in our culture. We have amazing speakers, Timothy Longo, police chief of the University of Virginia, where they had a major gun violence incident. Pardeep Kaleka, who is someone who has experienced gun violence. Jonathan Nathans with opening remark from the U.S. Attorney General's office. Darcy McElwee, who is the state attorney general for the District of Maine. So we've got quite an amazing panel. We want all of you to learn about these impacts, think about your patients, think about yourselves. And we thank you so much for being here. Thank you, Dr. Levy. Thank you, Sydney and Emily. You're amazing. And thank you, everybody, for participating so energetically. We appreciate it.